Okay. Well, we'll get started as folks are joining us. Welcome to the very first session of the 2024 Rural Oral Health Echo Series from American Institute of Dental Public Health. Again, we're so thrilled that you're here with us today. And very excited to get started with this session in particular, but also with our Echo Series for the year. So without further ado, we'll move forward to our agenda. Perhaps if I can advance our slides here. Okay. So I'm going to do a welcome check-in, go over some housekeeping and what the call will look like today. We'll then move into our didactic presentation from Alan Morgan. We'll have some time for Q&A after that presentation, and then we'll move into our interactive portion with a think tank presentation and discussion of a case study review. We want to take a moment to thank our ECHO partners, UNLV, NRHA, with, again, Alan Morgan is here with us today, the Southern Plains Tribal Health Board, and the Open Progress and Equity Network. Some housekeeping pieces today as we share our time this afternoon. We are recording this session. Please stay muted during the call until our interactive portion. All session materials will be available on the AIDPH website after the session. Please avoid PHI on this call. Be respectful and mindful of that piece. Please jump in the chat now and share your email, your organization, your name, introduce yourself as we can all kind of get started with our community collaboration. And if you have any issues with Zoom, please pop that in the chat as well, and a team member from AIDPH can assist you with that. Oops. Okay. So we want to start off with a little bit of information about the American Institute of Dental Public Health. Our mission is to empower our community to advance oral health through science, education, and advocacy. And we're working towards a justice-oriented oral health system. We have 4 communities of focus, which include LGBTQIA+ people, veterans, people with disabilities, and rural communities, which is what we're talking about here today. And we work on our mission and our vision and working with these communities through our academy, which again, this programming is part of today. Our academy is a diverse range of programming that we have to bring education, professional development to the dental public health workforce, ranging all the way from a one-time standalone training or webinar, all the way up to our in-person colloquium where we meet annually. The ECHO model, I want to talk a little bit about that today. This is what is shaping our call. It's a telementoring model that's built for workforce capacity. It's case-based learning. It's a hub and spoke model. It's an all teach, all learn model. And some of the norms that we use to make sure that we're adhering to this model is, again, it's all teach, all learn. We use first names to facilitate equality in the discussion. Please add your pronouns to your Zoom name and always introduce yourself when you're coming off mute and talking. Please turn on your video if you're able to participate in the community. Limit environmental distractions and be respectful. So again, this is the very first session of our 2024 series, and we're super excited to be kicking off today. Our theme this year with ECHO programming, we're doing it in partnership with the Southern Plains Tribal Health Board, and it's designed to address the complex oral health challenges that pervade both rural and tribal communities. And this series will focus on the shared barriers, such as limited access to healthcare providers, socioeconomic challenges, and cultural factors that influence health outcomes. And we think that by looking at these issues in tandem, we're respecting the nuances of each community while addressing the common obstacles they face. And I'm going to go back one more piece. So if you've joined us on an ECHO session before, you know that we offer CEUs after each session. It's required to participate fully in the session. We'll post the link for that information at the end. And we're also offering a certificate for participating and completing a competency evaluation after all of the sessions. So we'll have information on that after the session and throughout the year with this series. This is just a highlight of the upcoming sessions. We'll also provide registration information for our next session in June, and we encourage you to get registered and join us throughout the year. The learning objectives that we're talking about today, We will identify the most prevalent barriers in rural communities to oral health care access. We'll assess community resources for addressing unmet needs in rural communities. We'll execute strategies promoting rural relevant policy solutions to address oral health care access. So Alan Morgan is our speaker today, and he does not have any conflicts of interest. And I just want to share a little bit more about Alan before I hand the mic off to him. Alan is the CEO of the National Rural Oral Health Association, as well as a member of the American Institute of Dental Public Health Board. He's been recognized as one of the top 100 most influential people in healthcare by Modern Healthcare magazine. And today we'll be discussing an asset-based approach to community engagement for rural oral health access and equity. And with over 33 years of experience in health policy at both the state and federal levels, Alan is a leading expert in rural health policy, and we're just thrilled to have him with us here today. So without further ado, I will mute and hand it over to you, Alan.
Oh, Liz, thank you so very much. And welcome everyone for a fast-paced look at rural communities, rural health, and most importantly, how do we approach communities from an asset-based approach? So the goal of this presentation is over the next 15 to 20 minutes, I really hope to provide a new frame for how we engage with rural communities going forward. Next slide, please. And next slide. There we go. Perfect. To that slide. Great. So as mentioned, I'm with the National Rural Health Association. This is a membership map to show the geographic area where our members live and reside and work. I hope everyone can find your dot on this map. That's not the purpose of this map. The purpose of this map is to hopefully give you an indication of where rural America is actually located at. The federal government has more than 70 ways of defining rural across all of its many programs. I think the easy way is just look where NRHA members are located at. The important thing on this map is just notice the shape, because that's going to come back when we talk about health disparities. Next map, please. So let's start with this. If you've seen any news article about rural America, rural health in particular, this slide sums it up. Either you get the photograph of the father and the daughter looking out into a beautiful sunrise into the future of rural America, or it's a story about workforce shortages, vulnerable populations, and chronic poverty. Okay, so let's be honest, the truth lies in between. It may not be Shangri-La, but it's also not a dystopian geographic area where people are either fleeing or dying to get away from. The truth actually is the fact that the challenges that we face in rural America drives innovation. And that's an important starting point to viewing and communicating with these communities. Next slide, please. So let's get right into the landscape. Next slide, please. And we're going to start with the slide that if you've ever heard a presentation about rural health, rural oral health, you've seen this slide. Older, sicker, poorer. It's the elevator speech of how we communicate why rural is not a small version of urban. It's a unique healthcare delivery environment. The population is older, sicker, poorer. That's a terrible marketing statement, but it does indicate the uniqueness of the population. Next slide. So let's get into the poor component of it. And you should see some commonalities between our membership map that we showed earlier. But I do want to highlight that from a rural perspective, the poverty is primarily in the southeast of the US. Next slide, please. This gets into the older and sicker component of it when looking at the prevalence of Medicare patients with 6 or more chronic conditions. Again, you should see a commonality between the membership map and this particular map as well. Older, sicker, poorer. Next map, please. So what happens when you have a population that is in high need of health access, whether from a medical standpoint, oral health standpoint, or behavioral health standpoint, and it meets up in a community where you have historic workforce shortages. Next slide, please. Well, that's the real focus, and that's the real issue that we deal with is the declining life expectancies among rural populations. Next slide, please. In fact, as recently as 2 weeks ago, the USDA came out with a report showing that there's a 20% higher natural cause mortality gap, rural urban. This actually matches up, unfortunately, well with the CDC data showing that in many rural communities, you could have up to a 20-year less life expectancy than suburban America. Next slide, please. And not surprisingly, unfortunately, the oral health challenges and barriers and obstacles that we see align across the board with this. And I won't go into these, but next slide, please. And that's part of the reason why after this presentation, if you go on to Google, Yahoo, Bing, enter the words rural health, our website's always one of the first ones that pops up, should be at the top 5. And we've created a rural oral health initiative where we try to put together best practices and policies into one-stop place where you can see what other communities are doing to address these challenges. Next slide, please. Okay, now I want to get to the point of dispelling a key myth that we have about rural communities, and that is the challenges that we face in oral health, or whether it's hospitals, whether it's clinics, whether it's behavioral health, is a challenge of dealing with low populations. And in fact, that these low patient rates are driving the challenges we face. Well, this map dispels that rumor. Again, what you're seeing is for rural hospital closures nationwide, they're primarily centered within the southeast of the United States. So recognize the shape of the map. If this map were actually reflective to decreasing populations, then you would see, next slide, please, a map that resembles this. There's actually one small slither geographic area of the US that actually is seeing depopulation. It's that narrow beltway within the map. If a decreasing population was impacting the challenges that rural providers are facing, you would see, next slide, please, this map, which is rural nursing home closures, again, which indicates those geographic areas where we're actually seeing a depopulation. Next slide, please, which is not this map. Okay, so now you can see the relation to the first map where I showed our membership population and these health challenges that we're seeing. What we're actually seeing from a rural health standpoint, from an oral health standpoint, is that we've clustered in these small towns populations with high health needs with the inability to pay in areas where we have shortage of workforce professionals. That's driving so much of this discussion about rural health that we see on a national level. Next slide, please. Okay, so that paints the picture that you've probably heard in every single rural oral health presentation that you've ever heard. So let me shift and do a hard shift. Great publication was released just last year. The Overlooked Americans takes a data-based approach looking at rural and urban, and lo and behold, they find that rural America is not a geographic area where people are fleeing from. Next slide, please. So this is Jackson County, Kansas, where I'm from, and it's a good example of what is happening in rural America. This is what you would expect from a rural county to see, but in fact, Jackson County, Kansas is an urbanized county according to the federal government. People are not fleeing from Jackson County. If I show you another picture of the lovely downtown, you'll see that people are staying, they're living, they're thriving, they're expanding. And in a rural area, when a rural area succeeds, it becomes suburban and it loses the definition many times of rural. So it gives a distorted view of what's actually happening in rural America. Next slide, please. Now, let me back it up from data. You would expect me, as CEO of the National Rural Health Association, to be touting how great rural is. So I want to actually tie data to this. And the University of Minnesota's age-friendly research does such a lovely job at that. Next slide, please. The University of Minnesota wanted to see where are rural communities thriving and what are the commonalities that are making them succeed. Next slide, please. And here is actually a depiction of where the top rural counties where you're seeing an aging population that is has great health status tied in with it. Next slide, please. Not surprisingly, what the secret sauce is the same as what if you have heard about blue zones and what drives blue zones, these healthy communities worldwide. We see these in rural component counties as well too. And what we're finding, and this is very important, is that rural has a competitive advantage over urban when it talks about the assets, whether it's in many cases clean air, access to good foods, and also an access to a health system. Next slide, please. But I need to be very important here. In all of these issues, we're seeing a commonality, but two things that have to be present are leadership and access to healthcare providers. Without community leadership, many times it can be the healthcare providers and access to providers. There is where we see these challenges among the communities themselves. Next slide, please. Rural providers and the access are paramount when it comes to the importance. Next slide, please. Okay, this is usually the point where I lose a lot of my members and say, well, you don't understand, my community is different. We have persistent poverty within our communities. We have historical challenges. Our community is different. And that's the reason why I want to make sure that I highlight the Appalachia Regional Commission's Bright Spots research. Next slide, please. The ARC wanted to prove the point that wealth equals health. We all know that. And so having access to economic data and health status data, they overlaid those two to make their point in the Appalachia areas. Next slide, please. And they got what they didn't expect to get. And that was these communities that with persistent poverty and economic challenges, lo and behold, they saw bright spots. Next slide, please. And the reason why I'm sharing this with you is these communities that succeeded, again, had the secret sauce of having providers available in the community and having leadership to be able to develop a culture of health within those communities. I just want to drive this home because I think what we're seeing and what I'm trying to indicate is that rural has what it needs to succeed. And these challenges are driving innovation in these small towns. And approaching the community from this asset-based approach provides a whole new way to look at how we're going to deliver oral health care within these communities. Next slide, please. Now, that's all easy to say, but let's all acknowledge that, and I mentioned the fact that it's driving innovation, we really do need new models of care going ahead. I think that's largely behind much of the push that we see on a national level of integrating primary care with oral health care. Those two have to go hand in hand, especially within rural communities. Next slide, please. Okay, to close this out, I want to bring it back to the community level. I want to bring it back to where rural populations live and work and thrive. Next slide, please. It's important to note, rural America is 80% of the land mass, 20% of the population, 80-20, 80-20. And it's home to the 4 Fs, which is food, fuel, fiber, and fun. Of course, the fun component. Now, I say that and you laugh, but the fact of the matter is, where do you plan to go on your summer vacations? Likelihood you're going to go hiking, fishing, camping, maybe to the beach. When people can go where they want to go to take their families, oftentimes, those are rural areas. Next slide, please. And so it shouldn't come as a great surprise that we're seeing a rural renaissance nationwide. I want to go back to this again because we're trying to break this narrative that people are fleeing rural America. The data does not back that up. The US Census Department since 2015 has shown rural populations have increased. Now, they have not increased at the same level as urban communities have, so it gives this perception that somehow they're falling behind. But the data does not support it, especially after the pandemic, which is promoting this ability for all of us to work remotely. And this is so very important. We've got to break this perception of rural as a failed state or a failed area. Next slide, please. So if it's so great, why are we facing with all these workforce shortages? Okay, this slide is not an inclusive look of all the quote unquote reasons why we have workforce shortages in rural America. Let me just submit, these are symptoms of the problem. They are not the problems. Next slide. This is the problem. This is the problem. And whether it's dental school, medical school, our current model is to take the best and the brightest who are almost always upper income urban kids. We train them in urban areas, and then we're dumbfounded. They don't want to work in Flush, Kansas. Who knew? Who knew? I think there's a move underway nationally. We're certainly seeing it in the case of rural residency training programs and of communities engaged in grow your own programs of making sure that kids from rural underserved areas know that they can have a career and a home within their communities. There has to be a push to have clinicians representing and looking like the populations that they serve. And again, it's how we're currently doing our healthcare pipeline that's driving this, not that there's anything particularly wrong about rural. And that's open for debate, and I'm happy to have that debate at any time. Next slide, please. Okay, it's not, you can't have a discussion about rural health and rural health policy without talking about the promise of technology. And I just do want to make the point that telehealth and telemedicine and teledentistry is a tool. It's not a replacement, but it is a necessary tool, and there's no path forward without incorporating telehealth in some component. Next slide, please. But I do want to make the point that if you're just looking at data, which we are, and this is a data-dense presentation that I'm sharing with you, that the expansion of telehealth is not happening in rural America as is being portrayed in the media. While widespread adoption and practice of telehealth and teledentistry, which is an emerging tool as well too, is happening in urban areas and in health systems, it still lags behind in a rural context. So just want to make sure we drive that point home as we wrap up this presentation. Next slide, please. So the takeaways from this, what is the point of this very brief 15-minute overview? It's again, how do we tell an authentic story about practice in a rural context? How do we engage our community members in an asset-based approach? Not sharing about the challenges we have, which are important because they drive the innovation, but recognizing and appreciating the inherent strengths that rural communities have when you are setting up a practice or when you're delivering care within a rural context. Granted, there still needs to be new models developed to realize this at the full potential, but there is this policy link between oral health and the social determinants of health that we have to address going forward. And I hope, next slide please, that in conclusion, this backs up what you may have already thought about rural practice, but you just didn't have the data behind it to have this realization of the inherent competitive advantage that rural communities have. So thank you, and I'll turn it back over to Liz.
Thank you so much, Alan, for bringing your passion and that data-informed oversight to us. That was really wonderful. I'm actually going to stop sharing for a moment. We have a really robust group here, and we want to allow for time for Q&A. So I'm coming off of the slides so that we can all see each other as we have a discussion. And since we have such a large group today, I ask that if you kind of raise your virtual hand for the questions you might have for Alan. And Annalise, I'll pop over to you too if there was anything in the chat that came up while I was sharing my screen. Okay. All right, well, I will pause and let folks chime in with the questions they have.
Liz, I'm happy to start us off. Alan, great presentation as usual. I love all of the data and really appreciate the context of an asset-based approach. I'm curious if you have any thoughts or feedback. So AIDPH, we focus in 4 core areas, one of them being rural, but also veterans who are disproportionately located in rural areas, LGBTQIA+ people, and people with disabilities. And it occurs to me that all of all three of those people can live in rural areas. You know, rural people are not a monolith. There's actually a lot of diversity in rural areas, which is really wonderful. And you know that better than we do. So I'm curious about how we leverage an asset-based approach, recognizing that rural areas are so incredibly diverse. And you can't really, what works in one area and what works for that culture and that community won't necessarily work in the next rural area than maybe in the county over. So, you know, do you have any thoughts there of honoring the culture and the diversity and the uniqueness of rural communities while also kind of figuring out these frameworks and approaches that are asset-based?
Yeah, Annalise, thank you so much for that. And I think it goes back to that opening slide where you see the two perspectives of rural America. And it's really important not to get wrapped up. And again, I never want to be the person to get the perception that rural America is Shangri-La and it is the best place on the planet. But I will say this, because of to your question in particular, because of the workforce shortages and lack of access that you do see in rural America, one of the things that the data shows is, I will go to the Institute of Medicine's study, Quality Through Collaboration. Rural providers are more inclined to network and collaborate for solutions than from an urban standpoint. Where in urban areas you have that intense competition to provide services, in rural communities, what we're seeing is collaboration between the local health department, the primary care clinician, the dental office, the hospital. I want to stress that. So when it comes to underserved populations or marginalized communities, there is that opportunity to cut across these different provider types and outside of the healthcare field to address the issues and concerns. Especially in the disability community, where you have the ability for the local practitioner to work with the social services within the community to ask the important question, how do we meet the needs of our community where they're at in particular? So you are right, one community, you've seen one community, but what you do have is this concept of innovation in a rural area, collaboration and innovation to bring it to bear. And I would strongly encourage that again and again when we meet with our members and we see success stories. It is where they've gotten outside of the specific field of oral health and brought in the medical, the social services, and even the community leaders into it.
Thank you, Alan. Does anyone else have any other questions? Oh, I see some. Oh, that's you, Annalise, in the chat. Are there any other questions we have from folks?
That was the fastest paced rural health policy overview you will hear this year.
Okay. I'm not seeing any hands raised, so I'm going to move us on to our case presentation. But if something occurs to you, please post it into the chat and we can capture that and get your question answered. These slides will be shared after the session and Alan's contact information is in there as well. So I'm going to pull back our screen slides. Okay, so we have a case presentation. And it's going to give us an opportunity to come together in some small breakout rooms and do some interactive discussion, hopefully employing the lens and framework that Alan just gave us in his overview. So these are just some general pieces about the case we're talking about today, and I'm going to share some additional details. So we're talking about a town in the USA today, a potential town in the USA. It's a rural community in the United States where accessing dental care poses significant challenges for residents like Jack, who uses Medicaid as his primary form of insurance. The town we're talking about today is located approximately 50 miles away from the nearest city, making access to urban dental clinics difficult for residents without reliable transportation. The closest dental clinic that accepts Medicaid is located 30 miles away, requiring our patient Jack to travel a considerable distance for treatment. Additionally, that clinic often has long wait times for appointments due to high demand. And so kind of as Alan said at the top of his presentation, these are some challenges that we often hear when we're talking about rural oral health. However, despite these challenges, our town also benefits from several nonprofit and community organizations dedicated to improving healthcare access, including it's the Town Health Center, which provides primary care services, but does not offer dental care. Additionally, the Town Community Outreach Program offers transportation assistance to residents in need, although it does not specifically cater to dental appointments. The community culture in our town is characterized by a strong sense of tight-knit community bonds, with residents often relying on one another for support in times of need. But there's also a prevailing stigma around seeking medical and dental care due to limited resources and financial constraints. And those factors exacerbate the challenges faced by residents like Jack in accessing affordable dental services, underscoring the urgent need for innovative solutions to address oral health disparities in rural areas such as our town. So we are going to go into breakout rooms, and we are going to pop some discussion questions into the chat. I have them posted here. I will share that often in our ECHO series, we will get into some good deep discussion and don't always get to all 3 questions. That's okay. So as you go into your group and are facilitating, if there's a question number 3 speaks to you more than question number 1, please feel free to start there. We will come back at about 10 of, little before, to do a group share out. And so we will pop you into your breakout rooms now.
Maybe not a long-term solution, because like the dentist has to come to the, you know, the school. It's not easy for, like, you know, the kids necessarily, if they have a like broken tooth or something, to have a dental home, you know, as well. Anyone else have any experience?
I think a lot of communities are having some pretty good luck with the community healthcare worker. I think that can be a really great tool, especially if it's a tight-knit community. You know, hiring someone who's in the community, familiar with the community, I think could be helpful for that. I know, and I live in North Carolina, and in some parts of the western part of the state, I think they've been piloting some community dental health workers, which has been difficult but somewhat successful as well. And then another thing that I was thinking that you could potentially lean on, especially for question number 3, is you know, kind of meeting people where they are. So sort of bringing like teledentistry into the medical facility. So if someone's in their primary care office and they're having a dental problem, you know, it's fairly easy to use like an intraoral camera to take pictures and things like that to hopefully at least get the real emergent situations, you know, out for care. So those are just some first thoughts.
I think something like that would definitely work. I don't know if you could do like medical dental integration in existing healthcare centers, and like you said, incorporate the teledentistry in that aspect. So you could have the preventative side, having a hygienist in a medical facility, you could at least get that part implemented, and then of course linking them into a dental home. And the school-based dental programs are also great. Again, just giving some of that preventative, giving the parents the dental education, and, you know, teaching that home care and the importance of it would also be a big help in smaller communities.
I think also to expand the services and to build capacity, to maybe have the community work with the health centers to try to establish dental residency programs, because statistically, once someone works in these communities as a dental professional, they're more likely to stay.
I worked in California for most of my career. And as a dental hygienist, I was also able to get the registered dental hygienist and alternative practice license, where I was able to provide screenings and oral assessments. We partnered with Migrant Education. So that was a way to leverage that community resource so that we could provide those assessments. And then they had something in place where if we saw something that looked suspicious, that child would be referred to, there were dental providers available to follow up on treating that child. I currently live in Washington, where I'm on the Olympic Peninsula, which is quite rural also. And we have 6 Native American tribes here in this area. And there's one particular center in a neighboring town where they have a medical center, as well as a dental clinic there also. I'm currently, I will be submitting an application next week, actually, for an initial dental hygiene program for this area at our local community college. So we're hoping to be able to partner with the tribal clinic and work with them to gain, for our students to gain experience in that area. And most of our students will be coming from this area. So hopefully they'll bring that back they'll stay in the area and continue to contribute to the workforce.
I would like to add to the conversation. I like everything that everybody said thus far. In terms of Jack being able to actually get to dental services 30 miles away, possibly in some programs, I know Medicaid covers dental and in terms of transportation, and that was mentioned in the case presentation, that transportation is available for other things. So maybe on a larger scale to get some community support in terms of expressing that is a challenge when it comes to dental. Maybe they could include dental on the policy side for transportation services. But I think everything everybody else has said has already been, things that I would have said. So I don't have anything else right now.
Hello.
Oh, go ahead.
I would like to talk about the mobile units platforms to connect with people facing transportation challenges, and also the availability of residency programs that welcome internationally trained dentists in rural regions. I am from Brazil. I am an international dentist, trained dentist, and I live in Miami. And I would go to a rural area to do my residency. And I'm stuck with the situation that most of the programs in for example, Kansas, Montana, and they do not accept people with that is not permanent resident. So this is a problem. People are willing to join the workforce, and because of the immigration status, they refrain from joining the workforce.
Paula, that's a great point. My name is Heather. I'm from Indiana. I'm a dental hygienist, but I'm working in public health, trying to create programs. But I do think we have a large Spanish-speaking population in Indiana, and I do often find people who have gone to dental school, who are living in the state, who can't help out because of these barriers as well. So that's a very interesting thing to point out, because it does help, especially with when you have a language barrier. But I also wanted to say that the virtual dental home model, which I don't know if some of you are familiar with, that they used in California and in Maine, but bringing like a permanent, using dental hygienists to bring that permanent preventative care, and then also being able to coordinate care if they need it in the community. And that can be through not mobile, but portable clinics that could be set up in schools, community centers, and things like that, or even in the primary care offices. So I think that the collaboration with community partners is probably the key to the success of that.
I'm going to hop in. Heather, that was great. Thank you so much for sharing. I'm curious if folks have real world examples of success stories with that community engagement piece, or exploring how to kind of uncover those assets and make those connections. If folks have found strategies that are particularly successful that they can share with the group.
I can.
Yeah.
In rural Louisiana, northern part of the state, we have, and not just in the northern part, but are pockets in the state where we have no dentists in the area. And so we actually got a rule change to allow dental hygienists to work under general supervision using teledentistry. So the hygienist would, and this would be in school sealant programs, while going to schools during the school sealant program. And the hygienist would take the images, forward those to the dentist, who would say, you know, the dentist has to say whether or not you could seal a tooth. And then the sealants would be placed, the fluoride varnish would be done, and then a referral would be done to a dentist. Because the way the rule changes are written, we're working in areas that have help provider shortage areas. So there are FQHCs in those areas, most of which have dental clinics. But whatever reasons, the children are not getting care. So using a hygienist to actually be the one in the community, in the schools, doing the initial screenings and sealants, and then referring the children to the FQHCs to get care is something that we are currently in a pilot stage of doing, and wanting to write policies and our manuals for implementation going forward. So I would say that was the biggest success for us. And with that, we worked closely with the Louisiana Primary Care Association, as well as the Louisiana State Board of Dentistry, the Louisiana Dental Association, and the Louisiana Oral Health Coalition. So it was a collaborative effort, and we got buy-in from each entity to actually move forward. And community health center is actually the FQHC doing the services right now. So that's what I would like to share.
Celeste, where do you work for, or who do you work for that are you guys managing that project, or part of a collaboration?
Okay, so I work for XHealth, which is a federally qualified health center. And my director and I both were like the policy chair and co-chair for the Louisiana Oral Health Coalition, and that's how we got involved. And during those policy committee meetings, it was brought up about the need for dental care in areas where there were very few dentists or no dentists. And from those meetings were recommendations and suggestions from the people who were on the calls, because this all happened during COVID. And so we were able to meet with people with the LDA, present with them to them about the shortages, which they were they knew there were areas where we have a multiple dental providers, but weren't as keenly aware of the shortage areas. So that was a whole educational piece that, was like, oh, we didn't realize there were areas that didn't have dentists. And then when we looked at what communities had community water fluoridation, it was the same areas that didn't have dental providers. So you take those two things, put them together, of course, there's going to be greater incidences of dental disease. And so we were able to get buy-in just from that. And then because we're FQHC, we're attending meetings all the time with the Louisiana Primary Care Association. So we brought that to them, and they were like, well, we should be able to help to support, doing this on a broader scale. And they were interested. And then from there, we got other community agencies and groups that were interested in what we were doing. So every time that we're out, we're talking about teledentistry and what's going on in other states. And, Louisiana is very conservative. So they're not one to give us general supervision, period. So get it for teledentistry was like really a big win.
That's a great win. That's amazing.
Yeah. So thank you guys.
I think we'll be popped out into the main session, but did Celeste already pop out? I was gonna see if it sounded like maybe she had some resources that they were developing. Maybe we can ask if they can share.
Liz, we're all back.
Okay, great. That's what I was just going to ask. Thank you. Well, I hope everyone had a fruitful discussion. We had a wonderful discussion in the group I was in, and we have a few minutes before we do our closeout pieces to do some share outs. So I just invite folks who are in the breakout rooms, if you want to share some main points and takeaways, or maybe a really particularly great story that came to light while you were in your discussion. And we are still covering 2 pages. So if you want to either just pop off mute and share or raise your hand. Okay, well, I'm going to start off with a share, and then maybe I will prompt some other folks. And Celeste, I hope you don't mind if I call you out. Celeste Terry, who's at the top of my screen here, had a really incredible story that she shared about some wonderful community collaboration and a great success story. So Celeste, I didn't know if you just wanted to briefly share. I know it was a pretty complex story, and the other piece that I was particularly interested in, it sounded like y'all were developing some manuals or maybe some technical assistance documents that folks could maybe see for if they wanted to implement a similar program. So maybe if you could speak to that as well, that would be great.
All right, so we were able to get teledentistry passed, where dental hygienists working in FQHCs would be able to work under general supervision for school sealing programs. And then once we did the screening, sealants could be done once the dentist did the exam using teledentistry. And then we would do the sealants and fluoride varnish and then refer to the FQACs to do the follow-up care if care was needed. So that was the big piece. We're in a pilot project right now. So it's been launched with community health in northern Louisiana. And we're currently, the next step is to begin creating and developing the manuals so that we can launch teledentistry on a larger scale across the state. So in Louisiana, dental hygienists can only work under direct supervision with general supervision only if you work in a governmental agency or a university. So that was a huge win for hygienists in Louisiana. So we're excited. We hope to be doing more, and I appreciate the ability to share out with you guys. So as soon as resources are developed, we will gladly share out. Currently, we have drafts naturally because we're working and we're doing this. And okay, I know one of the things that came out was a problem with connectivity in terms of the amount of time it was taken to transmit. So we're working through those types of issues right now. And then data collection and the referral process, all that has to be refined. So that's where we are. And thank you.
Thank you so much.
Sorry, Liz.
No,
Can I
no,
add
go ahead.
with Celeste, what was really good that she kind of left out was like all the people who partnered to make it happen. So like, that's what stuck out to me was how you were able to get like, you listed just a list of community partners that came together to make it happen. So I don't know, Celeste, if you could go through that list again just to share. You're on mute.
Not a problem. Yeah, not a problem. So it was the Louisiana Oral Health Coalition Policy Committee and the Louisiana Primary Care Association, the Louisiana State Board of Dentistry, and the Louisiana Dental Association were the initial contacts that we made. But with buy-in from each group, we were able to gather enough support to get the rule change with the State Board of Dentistry. We had to do some education with Louisiana Dental Association because they were not aware that we didn't have dentists in certain parishes. We call out cities and county. We don't use counties, we use parishes. So we had some parishes that had no dentists, and we knew we had a lot of dentists in the state, but the concentration was in more of the urban areas. So that was like an area that LDA was not aware of at the, so they were willing to buy in. And then the Louisiana Primary Care Association is the organization that has all the FQACs that come together and they help support what we do. And by us wanting to use the FQAC model, that was a buy-in for them. And of course, Louisiana Oral Health Coalition was the one that, the committee that started it off in terms of like, what are the needs in the state and what we should be working on in terms of getting dental providers in rural areas. And because it was during COVID, there was like the promotion of teledentistry and telehealth visits. So we were exploring that whole option as well. So it was just the right timing and the right partners at the table and the collaboration. It worked. So we're in pilot stage right now.
That's amazing.
Thank you, Heather.
Again, Celeste. We have just a minute before we have to close out. Jamie, I did see you had your hand raised. I don't know if you wanted to share something.
Just a question, and well done, Celeste. That's the direction our county is trying to move here in Northern California. We're getting there. We're trying to partner with our FQHCs. My question is, we have RDHAPs that want to start their own businesses, right? And those are even hard to find here. Right, but the idea is that we partner with an FQHC and then the RDHAP can bill for what they can do, and then the FQHC bills on their end. I just wondered, are the hygienists you're using, are they employed by the partners like FQHCs, or are they are?
So we did, because this was, we because when we started to talk about this, we weren't sure because Louisiana is a conservative state. If we had opened it up and said, hygienist, quote, any hygienist, it would probably not have gotten through the state board because they don't want to do general supervision. You know, it's like we have a lot of work to do in that area. So using an FQHC model, where we have dentists in those sites in shortage areas already, then that was the viable start point. And then we weren't doing everyone in the community. We were focusing on just children in schools, trying to increase the utilization rate for Medicaid recipients, trying to minimize the amount of decay that's prevalent in young children. Those were some of the things we were trying to bring the evidence-based practices into play to reduce the disease burden. So I think all of those things help to push us in a direction that provided for wins for the teledentistry piece with the general supervision for hygiene. So yeah, I appreciate what other states are doing with RDHAPs. I would love to move there and be, you know, a little bit freer with delivering care, but it's not so in Louisiana.
Yeah. Thank you again. Thank you for the group discussion and for sharing, Celeste, and hopefully we can share your resources in the future. I'm going to jump to our next steps. We just have 1 minute left here. So as we said at the top of the call, our materials will be posted to our website. We're going to pop the link to request the CEU into the chat here. We'll send it out via email as well, and you'll have about 48 hours to complete that. We're also going to pop in the link to register for our next session, which is in June. This year's series will be every other month. We'll have those links, those registration links and those topics posted to our website as well. So thank you again all for joining us for our very first session of 2024. Thank you to Alan for an amazing presentation. And thank you everyone for being here and participating in a wonderful interactive discussion and sharing your experiences. So everyone take care, and we'll see you in June for our second session.